slide that's been there from the beginning. The Health Visitor Implementation Plan started with a strong government commitment with a focus on improving public health, building stronger communities and bringing the resources together to be able to get the community to have things in place that will meet the needs of that community. A strong evidence base from neuroscience about the importance of being able to be involved from the antenatal period and particularly up to age 2 to make a difference for the lifelong course of the child and for the family as well, and about the need in making that happen to strengthen support to families and to strengthen the focus on parenting. Now, all of those were underpinned by key important messages from the government of prevention, early help, early intervention, things that you've heard right through this morning and through every speaker. Now, that policy context was then looked at in the health visiting context, and the health visitor ticks the boxes for delivering and supporting the delivery in every one of those national areas. So it was very plain to see early on that health visiting and the health visiting implementation plan was seen as key to driving forward a number of key government policies. The government commitment itself was in two main areas. One, to grow health visiting by 4,200 extra on a baseline in 2010, and that was because we'd seen a decrease in the profession and a focus moving away from core skills into more just looking at the higher end of safeguarding and the most complex needs, rather than all of the elements that health visiting should be covering and that are covered in the new health visiting model. But more importantly, for that growth in the health visiting numbers to be able and be there to support a transformation of the service so that services were delivered differently, innovatively, creatively across those areas to meet the needs, but with the one intention of improving the outcomes for children, families and communities. So on that background, the evidence was always there, but it's informed how we've been working over the 2 years and moving forward and looking at, and the evidence talks about the importance of early years in general, and hence why the changes to some of the services and the things that we're asking people to do are looking more at some of the antenatal period right through to those early years, and more links with children's centres, more links with the attachment and the ways that we're working to make sure that we're looking at that importance in the very early years. Obviously, the importance of children's health in the early years. We know that that has a big impact on not only the physical development and growth of the child, but also the psychological, emotional development, alongside many aspects that come from excellent parenting. The importance of good maternal health, well known. I'm not going to rehearse the arguments with you. You know that if you get good maternal mental health, you get better and stronger attachment and relationships with the child. And also the mother is in a better position to be able to work with the child and also to support good relationships in the family. And really key, we know that maternal mental health has the biggest impact on the child at age 3 and at age 5. Helping babies to develop. We know that the health visiting role has to focus in the new agenda about making sure that we are looking at development, that we're making interventions and referring on appropriately where there are difficulties or challenges to child development, because we know that actually we have more children who are entering school and able to communicate well, more children entering school who still are in nappies, more children who have all sorts of emotional issues and stop them from engaging. So that's important too. And we have the backed evidence of approach from the Family Nurse Partnership and also the Healthy Child Programme. All of that is background. You know that inside out, and you know that that is where the implementation plan came from. However, what I do want to remind you of is that the public health focus remains strong in the health visitor implementation plan. We know that it has been a strong remit of health visiting and in school nursing since 151 years ago. However, that public health message remains strong. It just is a change on what we're looking at. We're beginning to look at things again. Obesity, absolutely key. Obviously, we're looking at issues within that about the re-emergence of some nutritional deficiencies. We're looking at issues where we're talking about all sorts of components, the re-emergence of whooping cough, measles, and getting the immunisation rates right. So we mustn't lose sight in moving forward on the issues of public health. They remain strong in the implementation plan, and they're strong for the years to come. The focus for the first 2 years and ongoing has not changed. It's very much around early intervention and early help, as I said. It's about changing practice so that we're enhancing parenting strategies, recognising that we're still giving support on breastfeeding, but we're also retaining that issue of how do you work with people who are bottle feeding so that the closeness, the proximity, the talking to, the eye contact is right for the bottle feeding mums too. How do we ensure that we have that warm and engaged and attuned parenting? And the approach that you're using as health visitors and school nurses with the young people, with the mums, with the families, is around that, getting them engaged, and is still a strong focus moving forward, getting in at where the family is ready to start, using promotional and motivational interviewing, and ensuring that you have goals and plans that meet with people's wants and needs and aspirations. And that's all about the approach that we're taking forward in the plan. So 2 years on, what have we achieved? Well, we've actually achieved so much between us, and in fact more than I could have hoped for when we started the programme. In terms of the implementation plan at a national level, we've achieved everything that we said we would achieve. We wanted to engage and re-energise people about health visiting, raising the profile and making sure that people understood what health visitors could do. You can go anywhere in the country now, up and down, and ask people, and there is heightened awareness of the profession, what it can do, and what health visitors do. So we're seeing a lot of change there. Also, we wanted to promote the learning and the spread of good practice, and we now have the communities of practice out there. We've got a whole range of things on websites and in areas that people can access, which is about good practice. We have case studies from early implementer sites that are available for people to use, access and share. And we have been very much promoting the learning through the early implementer sites so that people can understand what people have done that worked, didn't work, and moving forward. We have done work on rejuvenating and refreshing the skills. We've done work on Healthy Child Programme e-learning modules. We've done building community capacity programmes, and we've also built on additional work within those areas. And I'll talk about what next shortly. But we've also been looking at the education for health visitors, what that looks like, what the curricula entails, what the CPD needs have been about. And we've seen massive changes across the country in almost every higher education programme to complement what the new skills and the new working needs are, yet still retaining the core and basic elements of the programme that will remain constant forever, the public health, the population needs, and all of those components which are key. We have promoted research, and we've been looking at research through King's College London on the role of early intervention and health visiting, and we're doing more research which will be coming out in the next few years. But we also have been promoting innovation and change by working with the service to look at what can you do before the numbers grow massively. What can you do that is different and makes a difference to families? And in many areas, there have been new ways of working and new practices that have been enabled just through people thinking differently and creatively about what they do. We have passed the 1,000 extra health visitors on baseline mark, which is great news, but with most growth happening this year and next year, and we are only slightly below our target that we expected, and there are plans in place for where we have shortfalls. And we have also developed professional guidance to support better working between and with other professions, understanding how maternal mental health fits and sits with other professionals, the closer work with the midwives, the work with school nurses. We are looking at other guidance we'll be releasing shortly. And we've also provided a better interface between policy and the service, working closely, particularly with early years and children's centres, to make sure that when we are working together with local authorities, when we're looking at the public health and the health outcome measures together, when we're working alongside similar agendas for outcome measures, that we are giving the right messages and working together on shared agendas so that we can make that difference to children, families and communities. So, having said that though, what does it mean in practice for you? Well, we've got the 49 early implementer sites which have made a difference. There have been over 200 projects and case studies being developed. And I can say that most of them have been reflecting the areas that we would see as priorities. Antenatal care being the start point and key, and people introducing antenatal visits again, getting better links during the antenatal period, particularly with the vulnerable mums. And we've seen a reintroduction of that where it had gone in most areas previously. Focus on transition to parenthood. More and more join up in children's centres and others on parenting programmes which enable different professionals to link together at a time when we can get the best messages out to parents. And a focus of working with the family on where their needs are. There's been the refocus that I said on public health, and many of the projects that have been taken forward have been about getting peer groups together to look at issues that affect public health, looking at exercise elements, looking at classes where people can talk about healthy eating, nutrition books for children have been developed, all sorts of elements there. The focus on maternal mental health, more mental health pathways have been developed. We have more and more work which is closely aligned with some of our colleagues in mental health services, and also support through other community groups, and the number of community projects has massively increased. I would also like to mention that we have now, where we had some of the early implementer sites looking at the 2.5 year review, 100% coverage of 2.5 year reviews in some areas, increases in others. We've also got more and more voices on in the children's centres, on the boards and the children's boards, so there's more unity there, and offering of more evidence-based packages where we can demonstrate a change which is essential for moving forward. In terms of what's still got to be delivered, our next bits and what you can expect out is domestic violence and abuse guidance to add to the suite of documents. But also we are procuring some training in domestic violence and abuse that will be offered to all health visitors in the autumn and winter of this year. You may have seen already perinatal mental health champion training being advertised, and that was as a result of the maternal mental health pathway, and then commissioned services that we identified that there was a need for more of an understanding in that area, because we know from the research that the more skills there are in perinatal mental health work, obsessive compulsive disorder recognition as opposed to postnatal depression, understanding what is needed, and some of the issues in domestic violence are going to be key for moving the service forward. We are also expecting to come out a relaunch of the Safer tool, which will help the interface with social services on getting a response, understanding the information that needs to be shared in terms of safeguarding issues and child protection worries. And we are also developing more and adding more masterclasses and suites of learning and CPD materials to the Building Community Capacity programme. I'm whizzing through these because I'm conscious of time and I'm conscious that we also need panel discussion. But in terms of what else we need to do nationally, we have planned and are doing this year and next year many events with local authorities and our public health colleagues to make sure that we are ready for 2015, to make sure that there is a joined up understanding, an understanding of the added value of the health visitor and where the interconnection is on the public health agenda, but also on delivery on their health outcomes. And we are also helping them to understand the role of the health visitor and the Fit with Children's Centre so that we can begin to amplify the absolutely essential service moving forward and what needs to happen. We're also doing work strongly this year and next year, which is on supporting our Health Education England colleagues in understanding what needs to be delivered through the mandate, to make sure that health visiting and the education and the CPD and the work with practice teachers and mentors is as robust as it can be. And we have an action plan that we're working through with them on making sure that nothing is lost. And we're also doing some very strong and ongoing work with NHS England to make sure that, again, everything that we have done does not get lost, that the commissioning intentions incorporate guidance where we have talked about the need to strengthen commissioning. Talking with them about, and they have developed with our support and guidance, the health visiting spec, which is very, very detailed, but also making sure that they are sticking to and delivering the mandate that's accountable to the Secretary of State. So although we have handed over some delivery of the health visiting agenda and how it's delivered and moves forward in the next 2 years to NHS Commissioning Board, NHS England and to Health Education England, both of those organisations are mandated by the Secretary of State. They have a mandate. And if it all starts to go wrong, the Secretary of State can intervene. So it's still led nationally, but some of the delivery has been handed over. And we, as I say, work is going on to ensure that there is sustainable services post-2015. And before it's even announced and you have the new document, we are working on a refresh of the call to action, not to change any of the key principles or direction of travel, but to reiterate some of the successes that we have made, to make it clear that there is no loss of momentum within the plan, and to very clearly specify what the next steps are going to be, and to make sure that that energy remains in the system. So that's still to be delivered, but that's the direction moving forward. And if we continue with the services being as committed as you all are being to making a difference, the growth continues in the way that it has been doing and to trajectory, and that's been monitored too. And there are recovery plans where places have dipped and all sorts working there, that actually we want to be in a place where we have a shared health and well-being agenda with others, where we are maximising the outcomes, where we're delivering care and can measure it. So the 2.5 year review and the population outcome measure that is being developed will be key as a measure for future successes in the earlier work. We need to continue on building and strengthening leadership, because without that leadership in the system, health visiting and the health visiting implementation plan could lose momentum or strength. And we have a very senior group meeting of the chief executives and chairs of major organisations with ministers, with Number 10, to make sure that the progress is understood and what's expected is understood. But we want to, in the future, as part of that, be working with people to make sure it's a positive experience. So don't forget that sustained focus on the service users' experience, on what families want and how they want you to work with them, but also ensuring that staff have a positive experience. We recognise and we're hearing that with the changes that are happening within the system, that the staff experience is not always good. So we're doing work to look at what needs to improve to ensure that there's strong preceptorship in the first year for people, that there is strong support arrangements, that there is a rollout of restorative supervision so that we can make sure that people are getting all of the support that they need. But we want to retain that we have the right staff with the right skills in the right place. And we need to continually look at how do we work with other services, how do we shape the local services to make sure that we're utilising not only the skills of the health visitors and the health visitors teams, but also obviously the school nurses and others, but also other staff who have an interest in early years. So it's around reshaping how we work better together to ultimately achieve the goal that is not altering in this service, which is improving outcomes for children, families and communities. And I want to end by saying thank you for all the ongoing hard work you're putting into this and the desire to see the success. Thank you.
Right, thank you very much, Pauline. Now, you don't often get an opportunity to ask questions from the Department of Health, so I know you've got to rush off, Pauline, but has anybody got a question? 1, 2, that's all we've got time for, so off we go.
You talked about quite a lot of resources, is there a website where you can access some of those?
Yes, there are several websites. You can access it on the health visiting website at Department of Health. And what I'll do is, to make it easier, I'll send out a link which gets you through, because you can get lost in the maze of the new government website. And Dave will make sure that it goes out to everyone so you can access those.
Thank you very much.
Can I just also say, I'll be mentioning at the end about the social media stuff, but every link that Pauline's thrown out today I've actually put on Twitter, so you'll be able to access it after, and I'll explain how you can do that. So everything she said's on there. I promise you won't need to, and I'll explain it at the end.
Okay. We had another question over here. Thank you. Or comment.
Right. I think that that's down to how the services are designed and how the teams are used, and there are initiatives such as you could concentrate on vulnerable families with some health visitors, you could have a lead on maternal mental health, you could have someone who's leading on asylum seekers, domestic violence. It depends how the service is organised, and that's down to local need and what the Joint Strategic Needs Assessment is saying is needed. So I see a future where you'll have more specialised roles and more working so that you are grouping elements. But what we must not lose sight of is that actually the health visitor is always the one who's going to be there identifying the early needs and risks, knowing from the population information, knowing from the local needs, and knowing from visiting the family in the home and the other information what is most likely to be needed. Now, getting those early components sorted for what intervention is most needed and how and who can deliver. I think some of the future skills for that resource and spreading thin is around knowing who you really feel that you can trust differently to deliver new services. Some of it can be delivered with a health visitor setting up a group and then stepping back. It doesn't have to be continued. Some of it can be working with the Children's Centre to give a framework of what's needed, and it's delivered there. There are lots of new ways where actually you can reduce that thin spread. Clinics can be run differently with a health visitor in a separate room, so that if an issue comes up with that general, you're working with the families, a general weighing, nice way to get people in, the usual bits, that in the conversation something comes up, that you're almost straight in to see the health visitor for resolution or discussion, or to know if another meeting is needed, rather than, oh well, we'll come round, it'll be in 3 weeks' time or whatever. So responsiveness. So using things differently can often be a solution. So I think it's a bit of both and. One, professional judgment and influencing how the service is designed. I think it's about innovation and trusting and using others, and getting services up and running and supporting elements there. And I think it's about innovative and thinking differently about what would be more successful. Using IT more effectively. People are now using the Digital Babies programme more and more. The CLIPS Digital Babies is a programme where when the parents book in at the first antenatal appointment. They get access to texts monthly, weekly on the progress of their child, what's happening, special messages, but there's also links in there for little video clips on breastfeeding, temper tantrums, and they go up to now age 18 months, you know, little clips at the right age for what might help. Getting people to access those things can be helpful too. So.
Just ask one last point. It links in with the last question and one of your points in your answer. This group that you mentioned where the minister sits in, are you able to communicate the concerns about, for example, the closures of children's centres at the same time that you've used that as an example of supporting health visitors?
Yes, we can. But there is already a group looking at issues around children's centres. I was at a roundtable meeting yesterday where we were looking at the very issues that you're referring to. Now, the spending review, the cut in services and finances is something that we are here and living with. So it'd be wrong of me to say that we aren't discussing better how do we get more with less. How do you change what you're doing in a way that improves it? And some of the children's centres leaders were talking about differences such as clustering, differences of virtual children's centres, differences of how they're targeting to the most vulnerable groups. And I know that has some implications in terms of who picks up what in the other areas, but they're too looking at what they can do. And putting the two agendas together does give us opportunities. But we are, in answer to your original question, which was can we highlight the concerns about children's centres, it's already been raised and there are roundtable discussions about how we can better utilise early years, children's centres staff and health visiting together to achieve what we need to achieve.
Thank you very much indeed, Pauline. Could we show our appreciation to Pauline because she has to run off to... thank you very much indeed.
Thank you, and I'm sorry I've got to dash it, just I'm speaking again at 1 o'clock somewhere else I've got to go, so apologies. Thank you, everyone.
Thank you very much indeed. I'm going to take a few more minutes of your time before lunch because Avis hasn't had the opportunity to answer any questions or queries. I know we're running just a couple of minutes over time, but did anybody have a particular question or comments? We have somebody here. Thank you.
You mentioned as safeguarding. I don't sort of see GP in any sort of child protection conference. They haven't got no input. They don't know their families who are on the register. They don't know anything, neither them or their practice nurses or anything. So what's their responsibility?
They've got specific guidance from the GMC, and they are part of a statutory organisation in health. So they've got the same responsibility as any health practitioner. And there's a lot of work to be done in some areas about how you bring on board the governance around GP practice. They probably need a named GP to lead that interface and to work with their designated professionals. I'm very blessed, actually, in Lambeth. We've had very good involvement with GP practices. They can't come to case conferences, but they can make a contribution by sending a written report, or they can contact the chair. And it's also something you should raise with your LSCB. You need a multi-pronged approach. The LSCP needs to look at GP interface. The CCG as well as NHS England, they all need to come together and challenge GP practice. They're no different from any other health provider. They have specific difficulties because, of course, conferences are held in the morning when there's surgery and in the afternoon when there's surgery. So they've raised that, and we've looked at issues of can we do teleconferencing and whatever. However, only the first conference, they may not be able to make a contribution. Because it's sometimes called at short notice within 15 days. However, we've got other ways of reaching out to GPs. They can phone, they can be given a contact. I don't know if any of you have developed a MASH in your area, a multi-agency safeguarding hub. Well, part of the hub, or the health practitioners in the hub, will be reaching out to GP practices for their contribution. But it's work in progress. But they have the same governance as any other health practitioner.
I think I think the concern for most, all of us working in child protection is that now they're in charge of prioritising safeguarding. You've actually told us the CCG has a say. So the chap who is the head of our CCG is a GP. I don't think he's ever been to a child protection conference. So he's now in charge, and as you say, he's got the same statutory duties, but I think most people here roll their eyes and think, but so it's not as important to them, although they've been given that responsibility. And it does worry us because we, as you know, we drop everything for our safeguarding. We have to be there, we have to turn up. And it just feels like for years, and now the GPs are in charge of enforcing that.
Two things there. The strategic leads are your designated professionals for safeguarding. You have a designated doctor and a designated nurse who should use their influence, experience and organisational power and governance to support their chief executive around safeguarding. That's the first thing. Additionally, they'll be held to account by the LSCB, their Safeguarding Children's Board, which is separate governance. And the third bit, GP governance now rests with NHS England. So they're not performance managing themselves. So there is some room for negotiation. And it's about having that authority and power to say this should be in place. And it is work in progress. But things have changed very dramatically for GPs, post-Baby Peter and other inquiries. And in order to get through to transition, they have to have those structures in place. So you want to go back and find out who is your executive lead and who are your clinical leads, because once you've got hooked into them, that begins. Additionally, they're in commissioning. You probably sit in provider. And your designated professional work across the health economy. So your named professionals, as well as your designated professionals, can bring some leverage around that.
Is there one more comment or question?
The presentations have been really good, but I found that my stress levels, I think, have risen just listening to them all. Because, firstly, the Francis report one, we were told that our organisation can't ask us to do anything that means we can't work within our code. I think daily, actually, we're asked to do that because of our large caseload numbers. And then with record keeping, it's very hard to do what's been advised, because with Rio electronic records, so much information is required for us to write up those records. It can take longer to record a visit than to do a visit. Mm-hmm. So like half our day can be record keeping at least, and yet we've got pressure on us to have more face-to-face contact with our clients, and we've got huge caseloads. And then the early intervention project, great project, I'm sure we'd all like that within our areas, but for those of us not in Lambeth, we're having to undertake that role on top, as part of a large caseload. So with the large caseloads, it's, until the implementation of having smaller caseloads is actually worked through, we're just living under this stress the whole time, basically.
Part of our role, though, all health assisters are early intervention health assisters, because part of your role is recognition around which families have or may have difficulties based on your knowledge, skills and experience. And you need to somehow begin to gather that information across your caseload so that you can challenge commissioning. We brought about, all them years ago, early intervention because we fought for it. We said, actually, on our caseload, 6% of families are X, and we need to keep our own demographics, and we need to become more empowered and use some of those public health skills that we learnt about. And that's how you try and get resources. And you need to join up with your children's centres and others, but so you get a common theme about what the issues are in your area. Because even in Lambeth, we have different issues in different areas, but it's about that joined up working, GPs, health visitors and CYPS, to say, actually, in this area, we need this kind of service, and to influence commissioning or decommission things that aren't working well. But you do need to be putting that on paper and sending it up to your managers and asking them to put it forward to commissioners. Because these are often for families who have no voice. I know it's difficult, but in the old days when we used to collect data around, how many people are unemployed or whatever, it seems just common now, but it's really important. some of the national data about 1 in 4 households, single parent families. Well, if you add to that depression, drug and alcohol, you need a different kind of service for that area. And that information is very rich for commissioners because they're looking for ways in terms of early help to reduce the long-term spend. So if you can demonstrate that if we can change this service or have an additional service, in the long term it will work out better for children and families. I know it's difficult.
Thank you, sorry, I didn't mean to interrupt there, Avis. You did actually raise a very important point in terms of you saying that you spend more time writing up the record of the visit than doing the visit itself. And I wonder if I could bring in Jane and Joe to respond to your stress levels in terms of what's your response and advice. I think it's so important. Please, thank you, Joe.
That's okay. I'm sorry to have added to anyone's stress levels. That's the last thing I want to do today. It's a common feature of the cases that I've been involved with over the years in terms of when any clinician has an issue with record keeping. Very often, one of the reasons for that will be a shortage of the hours in the day. And all that we can do in that situation is to tell the story as it is, make sure that any evidence that we give in a witness statement fully addresses the nature of the workload that people are working with, the staffing levels within the particular organisation, day-to-day stresses of the role effectively. What we don't want to do is make excuses, so it's always a balancing act effectively in terms of making sure that also the health professionals' understanding of what the requirements of their role are in terms of what they should be achieving in an ideal world in terms of what the content of their record keeping should be. And that's all. In reality, that's all that I can do about it, or we can do about it when it gets to that stage. Unfortunately, it does seem to be an incredibly common theme within the NHS that there is an incredible amount of pressure on you as practitioners, and at some stage that has to be addressed. I don't know from what I've heard here today whether it actually in reality is necessarily being addressed, and things are changing within the workplace. It sounds like it's getting worse more than anything. But
could we ask Jane now to come in? And I think Dave, if you want to comment as well. So Jane first, thank you.
I was just wondering, is it anything to do with duplication? Because I've heard the same thing from other practitioners, that because they have to put it here and then they have to put it there and then they have to record this there. So I think some of that is about raising that with management, and actually maybe even going so far as to cost out, this is how long it is taking me to do this bit of the work, and actually the important bit is doing the visit. And because they need to deal with the duplication, that's the reality. They've got to go one way or the other. You're either doing it electronically and they're going to give you the equipment to do it so you can do it as you're supposed to be, or they're going to remain with the paper records. So I think that's probably the issue that needs addressing. While we're on record keeping, just to say we did redo the sort of short record keeping guidelines, and they're out on our table out there, but we're also in the process, we're just about to start rewriting the record keeping book, and the feedback this morning about something on safeguarding was really useful, and we can build that in. And we're also working with the authors of this book, which is around duty of care, which is really, really useful, very practically based, to make that available as well. So, we are looking at it, but I think it is something you do need to raise with your management. And Dave, did you have something to add to?
Yeah, it was just to sort of talk about how we've got to remember in terms of health visiting, the concerns that you raised today have been concerns that have been raised over a sustained period of time, and actually we've been continually raising those concerns nationally, and we've actually done a huge, amazing sort of amount of lobbying, and that's why we've ended up with the implementation plan, and that is saying that by 2015 you will have 50% more colleagues than you had in 2010. So it's in recognition of all those concerns that have been raised. And even though that won't put us in a position where, we'll have so many health visitors we won't know what to do kind of thing, it should be a much, much better position than it has been at least since 2000. And again, that is testament to the campaigning that's been done, not just by CPHVA as a national organisation, but our members, especially in London, that whilst working in some of the worst situations in the country, have continued to fight nationally to try and make sure this stuff happens. So, I'm constantly sort of, recording my thanks to the work that they've done. And really, the stuff in terms of next few years and 2015 beyond is really continuing that sort of promotion of the importance of health visiting, so none of these gains are lost when health visiting is sort of put out to local authority commissioning come 2015.
Thank you very much, Dave. Now, there was one, this is the last input.
Sorry. Do I leave it? Just, I don't know if I can give some reassurance, and I don't know if my reassurance is out of date, but I was on professional conduct committees between 1998 and 2008 as a UKCC member. And in my experience, the cases that came to us then, record keeping was always, part of misconduct or part of poor care. And I think the issues that we struggle with on a daily basis in terms of how do we marry electronic and paper records, how do we make sure that we demonstrate our assessment and our decision-making process when we're deciding on levels of risk. I think that's, we're all aware of that, and we're finding our way through that locally, and we need to make our managers aware of that. But I don't know if I can get some information from you on what the current state of affairs is in relation to record keeping being the primer case that leads to referral to the NMC.
It's up there. I think abuse of patients is the primary category, and then I think it's record keeping that falls in at number 2. Sometimes it's the sole charge, other times it's one factor of a number of charges that can relate to patient care. Sometimes it's in relation to one particular patient, other times it's in relation to a number of different patients. Unfortunately, the harsh truth of your profession and mine is that ultimately, when anything goes wrong, when a complaint is made, they turn to the records, turn to the file, and that is how you are judged in terms of the care that has been given. I've got clients who it's literally been 15 minutes of interaction with a patient that has led them to a fitness to practice hearing. Got others that it's taken 2 years to get there. But, it's just, it's difficult. But ultimately, the one you can only do the best that you can do on a day-to-day basis. If these matters are being raised with management, that's great because you've got some documentation that you can fall back on to say, look, we've been screaming and shouting about the fact that we need another 2 health visitors in this particular area because of X, Y, and Z. And as I say, the referral is not the end of the world. There are a number of different that 3-step process before you even get to a sanction level. So that's always something to remember, and it is always something that a regulator will take on board in terms of the working environment and the challenges that you face there.